Well, hello, good afternoon, everybody. Good afternoon from my point of view, anyway. I think it's rather later where you are. It's a pleasure to be able to talk to you today about recent advances and challenges in kidney disease in patients with diabetes. I'm not going to give you all the answers because we don't know what they are yet, but this is a tremendous challenge, particularly in developing countries as more and more people get diabetes and then unfortunately a large proportion end up with kidney problems. It's much better never to have diabetes or kidney problems, obviously, and prevention is tremendously important if it's possible to achieve. So I shall give you a perspective on this. It'll really focus on some of the therapeutic dilemmas and challenges that we have, as well as commenting on where we've got to so far with what we might call conventional therapies, the things that you and I are all familiar with, such as metformin. But one of the exciting things in diabetic kidney disease, or more accurately, in kidney disease in patients with diabetes, we have to be careful here to stick to definitions. One of the more exciting things is the role of new drugs that you'll have heard of, and some drugs you might not have heard of that might yet make it to the clinic. So, to start with, here is a sunny day in London. It does happen. I'll put it back, it's so rare. It does happen from time to time. In fact, we're having a heat wave over here. It is as high as 30 degrees centigrade, which I think you'll laugh at because over in England we can't cope with such a high temperature. I don't think you'll find it really that hot. So what we're going to talk about today is a number of things. We're going to talk about the epidemiology, mortality versus progression of kidney disease, the importance of multifactorial interventions as opposed to single factors. We'll be looking at blood pressure targets, the use of RAS inhibitors. We'll be looking at sugar control, lipids, inflammation, oxidative stress, and some other factors, novel interventions, etc. And we'll be examining all of this in early chronic kidney disease, that's basically proteinuria and GFR that's only just started to diminish, versus more advanced kidney disease, whereas we know it's very difficult to stop kidney disease from worsening. So let's get started. The epidemiology. We know perfectly well that the world is awash with people with diabetes. Many parts of the world, this is becoming a tremendous and absolutely insoluble public health measure. It is public health. It's all to do with diet, activity, foodstuffs, and we're moving in the world now from a problem of undernutrition to gross overnutrition, although that's not uniformly distributed, as we all know well. But even in Southeast Asia, there is going to be a doubling of diabetes over the next 25 years or so. And that is truly frightening and is likely to overwhelm healthcare services in many parts of the world, particularly in poorer parts of the world where there isn't universal provision. So that's just the background, which is pretty frightening. So the estimated prevalence will increase. Now, I'm going to show you some data from Europe. I'll build it to the next slide because you have all 6 of these. And this is the CKD, chronic kidney disease, that will happen largely, not exclusively, but largely driven by the increased prevalence of diabetes. And wherever we are, wherever we're starting from in 2012, there will be a slow but steady increase in chronic kidney disease. And that's what the epidemiologists are suggesting. And I don't think there's very much that you and I can do about this in terms of prevention at this stage, because already these things are already predestined and preordained. But it's a very sobering statistic, as you can see. This is really the sort of the beginning phase. Down here are deaths and dialysis, so they're rarer, but this will catch up as time goes by. So one of the first things to remember about chronic kidney disease is that at the end of the day, if you get people who are in CKD stage 3, A or B, but particularly actually A, what you'll find is that death is vastly more common of cardiovascular disease and other things than is progression to end-stage renal failure. So if you like, everybody looking after patients with hypertension, with diabetes, with greater age, with a number of other risk factors, you're actually honorary nephrologists because you're looking after people whose kidney function will get worse, but actually the treatments you're using are not kidney medicines, they're cardiorenal and cardiovascular medicines. And the kidney has no specific treatment in this context whatsoever. We will see a little later how some drugs that are relevant to diabetes do impinge on the outcome, but the bottom line is we are treating the whole patient holistically. We're trying to influence their cholesterol, their blood pressure, their blood sugar, and a variety of other factors and mechanisms to effect a change. It will not be enough just to study one thing like blood pressure and say my job is done, because one's job is not done with single risk factor intervention. So just to make the point again, it's about 10 times more likely that patients will die with kidney disease than it will be that they'll get onto dialysis and require that. So it's really cardiorenal protection that will reduce the total number dying and the total number getting through to dialysis. We all know this graph. This is basically, if you like, the annual transition rate from nephropathy and to death. Death is here on the right. What you've got here is no nephropathy, microalbuminuria, macroalbuminuria, elevated serum creatinine, and renal replacement therapy. You can see that there are rates of transition from no nephropathy to microalbuminuria, from micro to macro, from macro to elevated serum creatinine. At each stage, there's more and more death. As you go down and the kidney gets more advanced and damaged, death becomes more common. And there is, of course, a progression in this direction. What this graph won't tell you is of the faint but real prospect of reversal. Not so much with creatinine. You can't make creatinine get better, at least not yet you can't. But you can certainly treat macroalbuminuria and make that micro, and you can make microalbuminuria into no nephropathy, at least as defined by albumin excretion, not by renal biopsy. So there is a prospect of trying to get backwards, but unadjusted and untreated patients will get worse in this direction, down, and they'll get worse because they'll die. So it's down and to the right, unless we can intervene and do something about it. Now, we do know, if we go back a long, long time, 30, 40 years, certainly 30, 35 years, that we can reduce the rate of kidney function decline. This is mils per minute per month, by the way, not per year, per month. So multiplied by 12, and you're looking at around 8 to 12 to 15 mils per minute per year. And this was the old approach to diabetic nephropathy. If patients presented, they usually presented with heavy proteinuria, and they were usually dead or on dialysis within 3 to 5 years, and nobody could do anything about it. These are some of the very earlier studies, mainly from Denmark and associated countries in the Nordic regions, for the improvement you can bring to bear by the use of blood pressure therapies. You can halve or even a third or even a quarter the rate of decline by blood pressure control. So actually, at the beginning of the era, it wasn't really important what you used, because of course in the 80s there wasn't a lot to use to reduce blood pressure. There were beta blockers, there were the beginnings of calcium channel blockers, there was captopril, of course, at that early era, and then a little later enalapril. But it was much more important to get blood pressure control, and if you were able to do so, you could reduce the rate of renal functional loss from, let's say, 10 mils per minute per year down to 2 to 3. Now, we all know that the real amount we need to reduce it by is down to about 1 to 1.5 mils per minute per year. And a little later, when I show you some more recent data about trial interventions, you'll see that we've come some way towards achieving that goal. So what am I talking about with multifactorial intervention? And that's pretty obvious, but I'll take you through it. A multifactorial intervention like the STENO2 study, where we have aggressive treatment, and aggressive means trial-based treatment, of microalbuminuria with ACEs or ARBs or a combination. In those days, you could use a combination. You and I know now it's quite controversial to try to combine ACEs and ARBs, particularly in a high-risk group of patients like diabetes. We may come back to that in the questions. So this would be targeting hypertension, proteinuria, hyperglycemia, dyslipidemia as a form of secondary prevention of cardiovascular disease. And you can see here with an 8-year follow-up, intensive therapy versus conventional therapy. This was basically reaching an endpoint that might be renal, it might be death, it might be a stroke, it might be macro, microvascular. But what you can see is if you throw everything at this problem, you can get a 20% absolute risk reduction over a 9-year period. And what's interesting is that all the factors that you look at will give you around 15 to 25% absolute risk reduction. But it's very, very, very hard, at least with conventional, even intensive therapies, to do much better than that. At least it has been. So that's the sort of background. You've got the Garda paper from the Steno Centre, and that this remains a landmark intervention, and longer-term follow-up, which I'll show you in a minute, does just as well. The thing that doesn't really improve is neuropathy, but autonomic neuropathy, retinopathy, and nephropathy, in terms of development or progression of proteinuria, are very susceptible to this multifactorial intervention, which is at least reassuring. Long-term renal benefits, though, can come because there was a post-hoc analysis of the Steno-2 study with a total follow-up of nearly 20 years, actually, with a mean duration of the intervention of 8 years. But you know, wherever you look for this, if you intervene and get a benefit, you can actually see long-term improvements, even when that intervention may stop, because, of course, we do not know whether intervention is continued in the non-trial setting. So a paper published last year by Oligard showed quite clearly that there was long-term benefit. It takes ages to see the difference between conventional and intensive therapy, but if you then stop the trial and continue the patient's living, there is an improvement. Now, you can look at this two ways. You can be a glass half full or a glass half empty type of person. On the one hand, we have got sustained improvement, and the GFR differences now between these two groups are of the order of about 18 mils per minute after 21 years. Okay, that's definitely worth having. That's the difference between a drop of 3 mils per minute per year and 2 mils per minute per year over this long sustained period. The person who's a glass half empty would say, but look, even with intensive therapy, patients with diabetic nephropathy are losing kidney function year on year much faster than people who don't have diabetic nephropathy. And that is true. It doesn't mean we shouldn't strive to achieve this. It does mean we've only just begun the battle against diabetic nephropathy, even with quite modern and intensive therapies. Note as well that in this study that the GFR was measured properly with chromium-51 EDTA, none of this absolute nonsense of using estimated GFR for progression. That's absolutely unacceptable in a proper research study, although I see it all the time. So, another way of looking at this is the number of people who reached, if you like, a severe renal endpoint. So that's a GFR less than 45, or end-stage renal failure or death. And again, we can see that you only just start to see the benefit after 8 years of intensive therapy. But then if you do this 21-year follow-up, look what happens. You get, really, after the therapy is finished, and people go back probably to less good therapy, slightly higher blood pressure, slightly higher cholesterol, slightly higher glycated hemoglobin, etc., that they succumb to this combined renal endpoint of a low GFR, death, because death's a very big part of this difference, or end-stage renal failure. So there is some real palpable benefit in terms of a later stage adverse kidney and general patient outcome. And the number of years gained, you can look at this in a different way. This is the same study, but just identified in a different way and analyzed in a different way. And this 21 years of therapy with combination aggressive therapy based on Steno-2 gives you 8 more years of life. That's pretty impressive. There aren't many things that you could actually put into the frame that do as well as that. Of course, you'd like a lot more than that, as I've said, but that is clear proof that if we can bring to bear all the things that we know to work to our patients, very difficult to do. How will you get patients to have access to these therapies? How will you make sure that they're taking these therapies? How will you monitor them to make sure that they're doing well? It's a very different world out there compared to the trial setting. But if you could, this is what you could achieve. And that's a composite cardiovascular or death endpoint. And that opens up a wee bit earlier than the mortality alone. This is the cardiovascular events as well as death. And you can see that within the first 8 years, there's that big difference, and that is sustained over the following 13 years to make up 21 in total. And then if we look really at what we want to try and achieve, we want people to be alive with no end-stage renal failure, this green area here. We don't want yellow end-stage renal failure. We don't want diabetics with cardiovascular disease, and we don't want diabetics with other conditions. So what we're really wanting is this bit, the green bit, to be as much as possible. And with intensive therapy, you can see that there's a lot more green bit, particularly in the early stages. There's less end-stage renal failure, and there are fewer complications. And that's really the story we want. Now, these multifactorial interventions, what are we really talking about? Let's look at blood pressure. Can we look at trying to get lower blood pressure targets than in the general population? This is a really high-risk group of people. They've got diabetes and they've got CKD. Shall we be trying to do a sprint study and get these patients down to 120/70? Or is that going to expose them to additional cardiovascular risk? Because, of course, they've got widespread significant atherosclerosis, at least in many cases. And this is our concern about the J curve, of course. Now, most people with diabetes and kidney disease have at least a 10-year risk of atherosclerotic cardiovascular disease greater than 10%. It's usually much, much higher than that. So essentially what we're going to be looking at is the threshold of 130/80, trying to get them down to 130/80 or less if we can. In adults with diabetes and hypertension, we use all the classes of agents. If there's proteinuria, microalbuminuria, then obviously we're going to focus specifically on ACEs and ARBs, but we will then add in, because we will need to add in the other therapies one after the other. And these patients typically will end up on 3 to 4 different antihypertensives before you can hope to achieve good blood pressure control. We haven't yet mentioned things like a low-salt diet, which make an enormous difference, because low-salt diet is really synergistic with any antihypertensive, certainly with a calcium channel blocker and alpha blocker, and it's certainly, obviously, as you well know, very, very synergistic in terms of blood pressure and proteinuria when you consider ACEs and ARBs. But blood pressure control is really much more difficult to achieve in patients with diabetes for a number of different reasons, part of which might be autonomic, but there are other reasons too. So the reality is, as kidney function gets worse, even when I want to get 130/80 or less, I frequently cannot achieve that. And these patients essentially have a form of resistant hypertension. And as you know, resistant hypertension is difficult. So if we're going to look at this again, we're going to have a little bit more of a look at the RAS system and the RAS blockade. So what we can see here is the effect of RAS blockade at each stage of progression of diabetic nephropathy. You can have studies here at the very beginning that are trying to stop patients ever getting albuminuria in the first place, and even studies that have been done in pre-diabetes before diabetes has ever happened. Then you've got studies that are really looking at microalbuminuria to overt nephropathy and overt nephropathy to end-stage renal failure and death. There's a whole stack of them. There's the best evidence, really, for chronic kidney disease interruption in the context of type 2 diabetes. The original studies, of course, in the 1980s were type 1, but as type 2 has become 90 to 95% of diabetes, most of the recent trial data are in type 2 diabetes. So if you look at the comparative efficacy and safety of blood pressure lowering, you can do a network meta-analysis, and what you can find basically is fewer patients get end-stage renal disease if you give them ARBs. There's limited data on endothelin antagonists to date, ACEs and ARBs together, and there's much less evidence for calcium channel blockers, and indeed, of course, as we know, with direct inhibitors of renin synthesis. Of course, these populations are not exactly the same all the way across the board, but it's pretty clear that ACEs and ARBs rule the roost here in terms of people who've got significant existing chronic kidney disease. But don't forget, this will be ACEs and ARBs as the beginning of their therapy, but most of these patients will be on 2 or 3 other therapies at the same time to achieve good blood pressure control. And again, you can do a systematic meta-analysis. We did a systematic meta-analysis for the European Renal Best Practice, and it's in this paper here from 2015. And here, unfortunately, one of the big problems is that it's very hard to influence, just using blood pressure control, cardiovascular disease on its own. Remember, I showed you STENO2. I showed you STENO2 because STENO2 did have an impact on endpoints, including mortality, but it was multifactorial. If you're really only looking at blood pressure or proteinuria reduction, you know, and I know, that I can't show you that saves lives. I think it does, but I can't show you it absolutely clearly. The studies were underpowered. The studies were set up, in fact, for proteinuria reduction and some impact on GFR. They were never powered for survival. And to this day, we can only assume that there is a positive survival advantage, but there's no a priori reason to think that there isn't. There was a trend for a favourable effect on non-cardiovascular events, curiously enough, but what that means I don't know. And trends, of course, are not real. This p is 0.1, so it's no better really than 0.8 if we're honest about the whole thing. Now, I told you that there wasn't overall survival benefit, but obviously you would expect there to be renal protection. And there's abundant evidence in type 2 diabetes. When you define renal function decline as a doubling of serum creatinine or the starting of renal replacement therapy, abundant evidence that we can do dramatically better. Dramatically better, yes, but as I showed you earlier, even with STENO2 and the multifactorial on the overall mortality, I'm only getting 20% reduction. I'm not really curing this problem or reducing it really very significantly. Very valuable, very helpful. Don't forget that not all patients respond the same. One of the things that's badly taught and badly explained to doctors by people who think that guidelines are the beginning and the end of the intervention or the therapy is that some patients have dramatic responses to interventions and some are completely refractory to those interventions. And we mustn't forget that when we're looking at our patients, that each patient is an individual and we have to assess whether what we're doing is working. It's not enough to say you're on an ACE now, that's it, thank you very much, come back in 5 years. We have to document that reduction in proteinuria and blood pressure and maximize it as best we can to see whether we can improve the lot of this individual patient for the very best. Now, what about glycemic control? What target? What about these wonderful new drugs that we see in diabetes? How are they going to help us? Well, you know, and this has been looked at intensively, that actually, blood pressure reduction, lipid reduction, sugar reduction, the reality is that people have tried harder and harder and harder and harder to get better and better and better results by applying more and more and more of the same therapies. And it's pretty clear from diabetes that if you really push the boat right out, you won't get a further improvement. Mortality will not increase. It didn't increase, but it didn't decrease either. So you basically get standard therapy and intensive therapy looking just about the same. A bit disappointing, and it does beg the question what the increase in mortality might be due to, because you'd expect there to be a linear relationship between therapy and outcome, but not with glycemic control. And almost certainly this is because hypoglycemia is very dangerous, stimulates the sympathetic nervous system, and can probably uncover arrhythmias and sudden cardiac death in large numbers of people, and may also contribute to strokes as well. And the same thing is true in terms of chronic kidney disease progression, because in the ACCORD study, there were about 3,500, so about a third, 35% perhaps, of the patients met the criteria for CKD, and there wasn't any benefit, I'm afraid, for intensive therapy. In fact, there was a suggestion that there was an increased mortality by trying aggressive glucose lowering. And that doesn't surprise me, because kidney patients with kidney disease, have autonomic dysfunction already. They're dysautonomic. And then you're adding on top of that the stress of hypoglycemia. Doesn't surprise me that that doesn't really benefit. And getting these people down from 7.5 to 6.5 doesn't help you. You may as well make sure they are around 7 is the best place for them to be. 7, and really ideally not higher than 7.5. That's safe. Right down here doesn't appear to be safe, at least in the trial setting. So what about anti-diabetic therapies, nephroprotection? Well, metformin. Now, of course, metformin's going out of favor a little bit, not because there's anything wrong with it. It's just that some of the more recent drugs are much more exciting, at least that's how they appear. But there's little doubt that metformin is associated with reduced all-cause mortality in patients with moderate CKD. Aha, but I hear you all shout at me. Well, I will in a minute when you ask the questions, because you're going to say, but you can't use metformin in CKD, Professor Goldsmith. It's dangerous. That's not truthful. The guidelines may ask you to be cautious with metformin, but most responsible physicians will continue to use metformin right down to 30 mils per minute in terms of GFR. My practice is to do that. My practice is to use 500 milligrams only per day, not more than that, and to get patients to discontinue therapy with any intercurrent illness. You won't find that in the guidelines, but that I think is a sensible approach to maintaining the benefits of metformin. And certainly in the days when the only alternative to metformin was the dreaded insulin with the fluid retention problems and actually often not an improvement in sugar control because of patient compliance, then keeping metformin going, I think, was valuable. We also know metformin may well have some influence on kidney fibrosis, and if so, there's another reason to try to continue it. Of course, you can't use metformin in CKD stage 4. I mean, I say can't. Not many people will be brave enough to do that. But I would use it in 3B. That's my personal view on the matter. If you want to read the guidelines, you'll not be able to have such flexibility. Now, of course, that's all very well. That was our old friend metformin. But look, we've got a new situation now. We've got these wonderful SGLT2 inhibitors, and these are known to have a number of rather remarkable properties, because these are essentially therapies that just allow you to dump extra sugar by reducing glucose reabsorption. Rather remarkable when you look at where the receptors are. But what they seem to be associated with is changing tubular-glomerular feedback, reducing intraglomerular pressure, and improving GFR, particularly in the context of diabetes and chronic kidney disease. Now, these, of course, have been developed for improving diabetic control. And as I'll show you, it was quite a surprise, quite a shock to find that there was a spillover benefit on cardiovascular outcomes. Not expected, not predicted, and took a lot of people by severe surprise. So people have then gone back and said, well, why could inhibiting SGLT2 have such a dramatic impact on a number of different body systems? And actually, when you start to look into it, there's a number of different potential mechanisms. The glycosuria will improve diabetic control, not by a lot, but by a bit, and every little bit helps. It also induces a negative calorific balance, so patients may well lose weight. There's evidence of reduced inflammation. There may be improvements in the heart in terms of reduction of the fat mass around vital organs, and that includes the pancreas, the kidney, and the heart. There may be improvements in cardiac function because of reduction in fibrosis. There's also uricasuria and a reduction in plasma uric acid. Well, that's controversial. Does that help? Does that not help? There's certainly an improvement in blood pressure. Is that a volume effect just by dumping the sugar and the associated fluid? Or is there something more subtle going on? Is there an improvement in arrhythmias? Lots of questions, lots and lots of questions. But now many people think that SGLT2 inhibition will equate to cardiac and renal protection. Cardio-renal protection, the holy grail that we've been looking for these very vulnerable, very frail, and very at-risk patient group. Now, is it certain that this will benefit everybody? Absolutely not. Do we need a lot more trials to establish this? Yes, we do. And these are novel and expensive therapies. Should we be taking people off metformin and throwing these in their place? I haven't seen a metformin versus SGLT2 inhibitor study that's specific for these sorts of outcomes. So there's a lot of unanswered questions at the moment. But there do appear to be some beneficial effects. There's hints here in trials of beneficial effects on cardiovascular and renal systems. With empagliflozin, there are reductions in cardiovascular mortality and morbidity, and you can see them here. You've got the primary outcome, which is significant. You've got death from cardiovascular cause, death from any cause, and hospitalization from heart failure, rather a late benefit there. But almost certainly, I think, related to the reduction in plasma circulating volume. And you know, heart failure, if you like, is the new ischemic heart disease. Now that we're using statins in anybody that can move and breathe, as it seems to me, what you have is an epidemic of heart failure developing now all around the world. This is becoming the dominant reason for people to get into trouble. And that's why there's an enormous amount of effort going into the treatment of acute and chronic heart failure. I'm not saying stop treating lipids. Of course, you treat lipids. But this is the big new area in terms of therapeutic benefit. And quite a few different treatments can help heart failure in different ways. But there's no easy single bullet there. You can also see with the Canvas program published not quite a year ago, the same with canagliflozin as well. So you basically get the same sort of set of curves, slightly different population, but there's definite benefit there. Is it massive as a benefit? Well, I wouldn't say so. I mean, it's clearly there. It's clearly statistically significant. There's little doubt that, you know, in terms of numbers needed to treat, there's benefit here. And yet, again, it's an increment, isn't it? I mean, what I'd like to see is these treatment curves right down here, okay? And what we have is nearly overlying ones. So we are getting benefit after, let's say, a large number of months. But my goodness, there's a long way to go before we can say we've really made a massive difference to this particular problem. And again, the SGLT2 inhibitors a lower risk of heart failure. This comes through again and again. This is on a massive population database, and you can see significant reductions here in terms of all-cause death with or without the use of the SGLT2 inhibitors, and a lower risk of heart failure hospitalization as well. And this is true, actually, whether you have diuretics present or not, because what people have said is, look, this is simple. What these drugs are doing, they're simply driving our excess fluid with the sugar. So these patients are volume depleted. Well, you can still see the same benefit and effect with or without diuretics. So I'm not so sure that the fluid argument is completely convincing. And they're also saying, a lot of people say, oh, well, what you're really doing here is intensifying RAS inhibition. But the benefit of these SGLT2 inhibitors is seen with or without existing RAS-based therapies as well. So I think there may be something genuine and different here. But exactly what mechanism it's working through, I don't know. But this is what we need to answer to persuade people that it's worth the expense and trouble of using these sorts of therapies. There is some suggestion perhaps that these therapies improve pulse pressure, which is a surrogate for arterial stiffness. Patients with CKD and patients with diabetes, and in particular patients who have diabetes and CKD, have radically increased pulse wave velocity and arterial stiffness, which contributes to, in particular, left ventricular hypertrophy, fibrosis, and arrhythmia. And there's also a contributory factor to anemia because, of course, sorry, not anemia, angina, because, of course, in cardiac diastole, that's when you tend to perfuse your coronary arteries. And if the pulse pressure is lower, the diastolic pressure is lower because the pulse pressure is wider, then obviously you get a potential perfusion problem at the same time. So again, is it plasma volume? There is some evidence that plasma volume is a significant change. Changing the hematocrit is there. You could almost use that as a surrogate for the therapies working. And, you know, some people are strong believers that it's to do with that. There are still people who say it's a glycated hemoglobin, and there are others who say it's uric acid. So, you know, you have to take your choice here. It may be, you know, when I told you about STENO2 and lots of things happening at once, I began the lecture with, you know, it just might be that these inhibitors, SGLT2 inhibitors, are doing several things at the same time, and it's the cumulative effect of all of this that's making the difference in terms of outcome. I just don't know, and it's really hard to separate out these effects and take some away and add some more of others. Now, what about kidney disease? I've told you about the cardiovascular side. There is evidence that are suggestions of incident and worsening nephropathy being better on empagliflozin. And as a result of that, there are going to be big trials starting out now. And you know what they're going to be? They're going to be on patients who don't have diabetes, but in whom we're going to be using SGLT2 inhibitors. Now just think about that for a minute. It's an anti-diabetes drug. It's designed to lower blood sugar. It has, of course, a very low hypoglycemic risk or threshold. But if you could use these therapies, which may have benefit on blood pressure, on hematocrit, on uric acid, on a number of different factors, on patients with chronic kidney disease, maybe you could improve chronic kidney disease as at the same time as other things, but not really worry about the diabetes, because in this particular trial, it wouldn't even be there. Controversial, yes, but definitely worth doing, in my opinion, to answer that particular problem. And so you can see an improvement in incident or worsening nephropathy. You've got improvements in progression to microalbuminuria, a reduction in the doubling of serum creatinine, a borderline reduction in the inhibition of the initiation of renal replacement therapy. And this really, it looks very similar to an ACE inhibitor, but it's not an ACE inhibitor. It's a SGLT2 inhibitor. So these are the biggest things that have come to town, and I think these are as big in diabetic nephropathy as ACEs and ARBs were in the 70s and 80s. They're that big. Now, again, I do not know whether to give them to everybody. Is that feasible? Is that sensible? What would the baseline therapy be to which you are adding empagliflozin? I don't know. It's not clear to me that we know the answer to that. But there is definite hope and excitement in this field, and it's one of the few things that I can point to in chronic kidney disease that has any potential benefit in terms of intervention, because the rest of it's really depressing, quite frankly. So will we see these same favorable effects just in CKD without the diabetes? It is a possibility. It's such a big effect that I think there is some chance that we will. But until we do the specific trial and not try to sub-analyze existing trials, I don't think we can ever know the answer to this. There is evidence that the intervention benefits people with and without kidney disease that's existing already, but that's not the question I'm asking. I'm asking whether these therapies exhibited to people with no kidney disease at all will stop the kidney disease from happening, not stopping the other things from happening. I don't know. So, yeah, I mean, if you look at things like blood pressure and weight reduction, you get the same effect pretty much across the GFR situation. So, it's not that kidney disease patients are immune from the intervention. Think about statins for a minute. You know perfectly well that patients on dialysis get a brilliant reduction in their cholesterol if you use atorvastatin, but it doesn't save their lives at all. So you can change the cholesterol dial, but their lives are just as miserable and short as they would be. What we've got to see is the fact that they can respond by systolic blood pressure reduction and weight reduction to SGLT2 inhibitors. Does that mean they'll get the benefit? That's what the big trials are going to tell us in the next few years. Just for balance, I ought to point out that there are pleiotropic and non-vascular effects of the DPP4 inhibitors as well. Now, I think the evidence for that is less extreme, and I think the excitement that those are generated are less. And of course, you can't have both of these very easily at the same time. But nevertheless, I think these novel therapies for diabetes are providing potential useful benefit in diabetic nephropathy, and even possibly in nephropathy without the diabetes. Wait 5 years and we'll find out. I'll just leave that for going on. So really, the bottom line is that we have not yet got a clear-cut answer for the reduction of cardiovascular disease in this group of patients, except perhaps by using SGLT2 inhibitors. The GLP-1 antagonists and the DPP4 inhibitors, I think the effect there on non-fatal myocardial infarction and death from cardiovascular causes are pretty low. And this is a big meta-analysis done looking at the cardiovascular big trials and then sub-analyzing by treatment effect. I'll just mention magnesium very briefly. Why am I mentioning magnesium? Because magnesium has a big impact on the propensity to get diabetes, and magnesium handling is abnormal in chronic kidney disease. And we can see here that with reduced magnesium intake, you get an increased tendency to congestive heart disease, total cardiovascular disease, stroke, and actually even the incidence of type 2 diabetes. Because if you have higher magnesium intake, and in fact, higher magnesium concentrations in your blood, you do a little better, and that's good. And interestingly, to try and tie those two things together, canagliflozin was associated with normalization of magnesium in hypomagnesemic patients with type 2 diabetes. Could this be yet another way in which it's actually impacting beneficially on the outcomes of these patients? I don't know. I don't know. Serum uric acid, well, serum uric acid is certainly something that's highly thought of, but I think its place in cardiovascular medicine remains very, very vague. You can find evidence in the literature, if you look, for uric acid improving blood pressure, uric acid treatment improving blood pressure with allopurinol mainly, and also improving angina. But you know what? It's not a mainstream therapy for this. There are people like Rick Johnson and others who think that it's a really important part of chronic kidney disease, but again, it's not mainstream. And at the moment, intervention for serum uric acid is only really important in the context of active gout. So, it's one of those things that hasn't yet brought home the difference. But there are some epidemiological clues that there is a J-shaped curve. Patients who have low serum uric acid and high serum uric acid do worse in terms of overall outcomes, if you look at particular studies. But the evidence is weak. The numbers are not big enough really to do anything about this and to use it as a separate factor. So I'm going to sort of run over that a little bit. As I told you earlier, there is evidence that allopurinol, which obviously does a number of different things apart from reducing serum uric acid, can actually reverse LVH a little bit. It causes a regression of left ventricular mass. not by a massive amount, but it's done in very carefully controlled, double-blind, randomized, placebo-controlled studies. Now, that's not through uric acid, is it? So there's probably a number of different antioxidants and other effects that allopurinol is having on these patients, but it's not mainstream, and therefore we don't routinely use it. But I've told you about magnesium, and I've told you about higher magnesium reducing the incidence of diabetes and the complications. I've told you about how lower magnesium makes patients more susceptible, and SGLT2 does decrease serum uric acid in patients with type 2 diabetes. If you're a believer in magnesium and uric acid, you can see a strong rationale for potentially trying to intervene, but it's not mainstream medicine at the moment. I'm going to finish with some information around inflammation, fibrosis, and oxidative stress, because these are very fertile areas for diabetes and chronic kidney disease. And this will take us through to our 45 minutes. Now, there's always been associations between inflammation, if you like, and bad outcomes in chronic kidney disease, particularly in type 2 diabetes. So, for example, the serum levels of tumor necrosis factors receptors 1 and 2 are definitely associated with an increased risk of prevalent kidney disease. And this is implying that there is more tumor necrosis factors circulating, indicating perhaps there is more chronic inflammation. And if you try to use antioxidants, and there are so many different sorts of antioxidants, but you can use one called pentoxifylline. You know that pentoxifylline has been used to augment the action of erythropoietin because it's anti-inflammatory and reduces erythropoietin need in patients with CKD and on dialysis. Interesting that, isn't it? So it does work as an antioxidant, but it's also known as octapentaphyllene. But it's used, it's a xanthine derivative, so again, it's a little bit like allopurinol, and it's originally used to treat muscle pains in people with peripheral artery disease. It didn't work very well there, but curiously enough, when people looked at the studies, they found there was an impact on the progression of chronic kidney disease in CKD stage 3, some 3B and some 4. So there was an improvement. It was mediated through proteinuria reduction. Isn't that interesting? I don't know what that means in practice, and again, it's not a therapy that we can use, but at least not a conventional indication that we can use. But it does raise the possibility, as I'll show you with some more data in a moment, that if we can bring antioxidants into the clinic, we can augment the actions that we're already able to do with ACE inhibitors and SGLT2 inhibitors, and we might get better outcomes in the end. In terms of the protective effect in advanced CKD, a study was done in Taiwan. I have to say it's a poor study, and the impact is negligible. I wouldn't worry about it. There's another antioxidant called silymarin, and you can add that to RAS inhibitors and look at the effect on proteinuria, and there was an additional reduction in proteinuria using this additional antioxidant agent. And then I want you to look up, if you can, bardoxolone, because bardoxolone, originally an anti-cancer agent with bladder cancer, but like so many drugs, it was repurposed when it didn't bring home any clinical benefit in that context. It has a number of different remarkably different antioxidant characteristics and qualities, and it was being developed by a number of companies, including AbbVie and its predecessor Abbott, looking at bardoxolone methyl in type 2 diabetes and CKD stage 4. Now, as I've shown you already, the highest cardiovascular risk of all in our patient groups that we're talking about today is patients who are on dialysis or close to dialysis with type 2 diabetes. So this will be a very fertile area to see whether, even in the context of ACEs and ARBs and other interventions, bardoxolone as an antioxidant could do any good. And all of these papers come from the New England Journal. If you look up Dick de Joux, he's from Groningen in Holland, or look up Beacon in terms of the trial, or Glen Chertow actually, you'll find all of these particular trials. And what really the bardoxolone is a KEAP1 inhibitor. It's basically reducing the antioxidant cascades that are initiated by oxidative stress. So it's really damping down oxidation in the cells that are exposed to these sort of stresses. And what this Beacon study did was included adults with type 2 diabetes and GFR of 15 to just less than 30, super high risk people, people with poor glycemic control, uncontrolled hypertension or recent cardiovascular event or overt heart failure were excluded. And then they exposed them to bardoxolone with the endpoints of end-stage renal failure and cardiovascular death. Now, Let me hang on to your hats here, please, folks. Bardoxolone radically increases, yes, I use the word increases, GFR. It increases GFR by about 20%. It does it by increasing glomerular filtration rate. So if you use bardoxolone, your GFR here goes from around 22 to 28, 29. That's a heck of an improvement, isn't it? What seems to happen, though, is that you get some weight loss with bardoxolone. Now, what that weight loss is, whether it's fluid and muscle, remains controversial. And you'll see why it's controversial in a minute. But over a 56-week period, dramatic and sustained improvement in GFR, but an unexplained drop in weight. It could be that they were in heart failure and bardoxolone was making them work better. But I think you'll see in a minute that's not likely to be the case, because the patients, even though their weights were dropping, they had increasing incidence of heart failure. And this was unacceptable as a side effect profile. And the secondary composite outcome of a number of other risk factors was also dramatically higher in the presence of bardoxolone. So in the context of type 2 diabetes and CKD stage 4, bardoxolone seemed to be toxic. And as a result of that, it wasn't something that was able to be used. And as a result of that, it was dropped very quickly and the whole research program stopped. So you can see here the incidence of serious adverse events was significantly higher, particularly with heart failure, and not with renal impairment because that improved. But this was enough to make the Data Monitoring Safety Committee stop the trial early because there was no evidence that among patients with type 2 diabetes and stage 4 chronic kidney disease that this drug, bardoxolone methyl, could reduce the composite endpoint of end-stage renal failure or overall cardiovascular death. And that's because of increased risks of heart failure and and the other composite cardiovascular outcomes were actually more common. Published in the New England Journal of Medicine, October 2012. Do look it up. This drug has not disappeared, though. It's reappeared. And now people are using it all over again, but not in patients at high cardiovascular risk, not in patients with type 2 diabetes. They're using it now in things like Alport syndrome and IgA nephropathy and polycystic kidney disease. Patients who are younger, fitter, with no cardiovascular problems. They see an enormous improvement in GFR, a reduction in proteinuria, although not as much as you would expect with the increase in GFR. Some people say the proteinuria actually increases. And we'll see over the course of the next few years whether this is an intervention that works in a non-diabetic setting. You know what? I think it might. So curiously, it was a cancer drug that didn't work on cancer. It's an antioxidant that didn't work for diabetic patients, but it is a GFR improver that might bring home significant benefit to patients with mild to moderate chronic kidney disease and in whom there is no cardiovascular challenge. So eventually, we might find the right way to use this therapy. So what I've tried to do in this talk, I've tried to take you through where we are, what we're using, what the excitement is in this area, particularly with SGLT2s, and what things are out there on the horizon in terms of other interventions. I haven't, because of space of time, been able to mention endothelin antagonists. There's plentiful evidence that they have a potential role to play in diabetic chronic kidney disease as well, with antiproteinuric actions and improvements in GFR over the longer term and interacting positively with ACEs and ARBs, but without, interestingly, the risk of hyperkalemia, which you know very well is a significant risk with ACEs and ARBs in severe CKD. So I hope you found that useful. And now I would like you please to submit questions to me, and I'll do my very best to answer them over the course of the next few minutes. Thank you. As of right now, I can't hear anybody talking. So maybe I've got to talk through the answers that I'm seeing here, or the questions. So at what GFR rate is it? I'll do them as I see them. Somebody asks, what GFR rate is it safe to use metformin? Well, look, the higher the better. So if you're over 60, then you've got no increased risk of the worry that people have had, which they saw with tenformin, which was metabolic acidosis. If you look at this carefully, the evidence that there is associated lactic acidosis with metformin used responsibly is very low. I think it's safe to go down to 45. That's what I do. I think increasingly guidelines will say the same. Under 45, it's riskier, no doubt. You have to ask the patient whether that's what they want. You have to monitor the patient sufficiently. You have to use the lowest achievable dose of metformin, which is typically 500 milligrams. And you have to give the patient precise instructions to discontinue therapies in the event of intercurrent illnesses. And by the way, you should be doing the same for ACEs and ARBs. I hope you're all telling your patients to stop ACEs and ARBs with any intercurrent illness. So where do ACEs and ARBs stand well, they stand first and foremost. They stand there in any case of microalbuminuria, in any case of GFR reduction, and in all cases of microalbuminuria with GFR reduction. They remain the cornerstone. Do they work brilliantly? In some, yes. In the majority, moderately. In some people, not at all. In patients, in fact, who have high phosphate concentrations in their blood, there's excellent evidence by a reanalysis of the RAIN study by Zoccali et al. That patients with hyperphosphatemia are quite immune to the presence of ACEs and ARBs. So it's not a certainty, but if you don't use them, then you will be in difficulties. I would not use bardoxolone in diabetic nephropathy at all. The evidence is clear from the trials that it's too dangerous. But would I use it in other chronic kidney diseases when the trials clearly show 5-year safety horizon? I think they will, by the way. And when that's through, I think bardoxolone may well be licensed for use in prevention of progression. Can we still use SGLT2 inhibitors in stage 4 CKD? Yes, you can. Their tendency for hypoglycemia is very modest indeed. I think you need to be a bit more cautious with all drugs in CKD stage 4, but it's still possible. N-acetylcysteine, I don't believe that works in any clinical setting at all. Okay, that's my honest opinion. You'll find me a study here and an abstract there. No, don't believe it. So I wouldn't use it at all. I think you're wasting time and money doing that. At what level will ACEs and ARBs be stopped? Well, that's a tricky question. There's a very, very good study going on out of Sheffield, England called Stop ACE. The clue's in the title. And it's going to be in CKD stage 4, and people are going to be randomized with CKD stage 4 to stop ACEs and ARBs or continue them onto dialysis. There are two arguments. One is you'll get a payback improvement in GFR straight away for stopping ACEs and ARBs of around 5 to 10 mils per minute, quite significant actually, and you'll reduce the risk of hyperkalemia and a number of other factors as well. On the other hand, you might get much worse blood pressure control, you'll lose any cardiovascular protection, and you might get more rapid progression of chronic kidney disease. So, you know what? We need the study to show us. My practice, continue it, unless you're running into difficulties with ACEs or ARBs, and now, of course, we've got resins you can use, although they're not available everywhere. So these are tricky questions, but I don't think there's a fixed moment to stop them, except if they're causing side effects or problems. Are there ACE inhibitors that show greater mortality benefit? Well, not in kidney patients there aren't, because there are no studies that show mortality benefit, because there are none that have been set up to show that. They're all about the intermediate of proteinuria and to some extent GFR. Are there specific drugs to reduce proteinuria? Yes, you know there are, and those are the ACEs and the ARBs. But don't forget that the non-dihydropyridine calcium channel blockers are not nifedipine. Nifedipine doesn't reduce proteinuria. You can see that from the IDNT study if you want. That's actually amlodipine, I know, but it's still a calcium-containing calcium blocker that's of the dihydropyridine class. But the non-dihydropyridine ones do seem to reduce proteinuria. So what do I mean? I mean verapamil and diltiazem. Yes, they do. So it's not just ACEs and ARBs that do it. And they're much underused, by the way, because people have forgotten that. Can we give an ACE and an ARB together? Of course you can. But my goodness, you need to be careful, because it depends on what benefit you can see by using the two together. What are you increasing the risk of? You're increasing the risk of acute kidney injury if patients become dehydrated or get an acute illness, and you're increasing the risk of hyperkalemia. So if you're going to do that, you have to have a very good reason. What might that be? Severe cardiovascular problems, gross proteinuria, those are reasons, yes. What will you do if you do use the two together? You're going to monitor your patient really carefully. you're going to be sure that that patient can actually take the therapy properly, knows when to take it, and knows when to stop it. Otherwise, it's frankly irresponsible to start using those sort of combination therapies. But absolutely, you can do that, the two together. Let me look at some more questions. Give me a second while I scroll. Initial management of hypertension in newly diagnosed diabetes mellitus. Well, initial management of hypertension has to start with lifestyle intervention. Most of these patients are type 2, most are obese, most are taking too much salt. You have to start with lifestyle, unless they're uncontrolled blood pressure. If you do, you'll have a much less resistant patient. Obesity, stimulation of the sympathetic nervous system, and salt excess really short circuit the action of all antihypertensives. So, you must try to get these patients to lose weight because their blood pressure and their diabetes will improve. If that fails, if they have no proteinuria or albuminuria, you can use anything you like. If they have kidney disease, low GFR, less than 90, and in particular if they have microalbuminuria, you've got to start with an ACE or an ARB. I use ARBs, I don't use ACEs, but there's nothing wrong with an ACE. I would tend to use once daily ARBs. That's just my preference. If I had hypertension, that's what I'd like to take, once daily therapy of that sort. Which ACE do I use in my clinical practice, or where I use an ACE? In the United Kingdom, I tend to use Ramipril. It's generic, it's cheap, and it's quite well tolerated. I think, to be honest with you, I think there's little to tell between the ACEs and the ARBs. I think between the ACEs, there's almost nothing, and between the ARBs, there's almost nothing. And I think if you think there is, you're probably being susceptible to a little bit of marketing that's going on. ACEs versus ARBs, increasingly people are wondering why you would use an ACE when you could use an ARB. If there are generic ARBs that don't cost anything, I think I would probably go straight to them first to reduce the risk of angioedema. Not a big risk, but my goodness, not nice if you get it. And also reduce the risk of other side effects, including, well, there's basically angioedema is the main one, I would have thought in that sort of setting, because they both cause hyperkalemia. Centrally acting agents. What are you thinking of there? You're thinking of antisympathomimetics and things like that. And alpha blockers. Well, I mean, alpha blockers are the refuge of the therapeutically destitute, aren't they? I mean, we're not surely talking about doxazosin. You might be talking about sympatholytics. Well, yeah, I call those a boy doing a man's job. I don't see them as being very well tolerated drugs. These are back a generation or two. Of course, if I've got a patient who's on 3 or 4 different classes at maximum therapy and I know they're taking the drugs and their blood pressure is not controlled, I am going to be reaching out for these sorts of therapies. Don't forget spironolactone or similar drugs as well. Of course, it's difficult to use with an ACE or an ARB, but it's just as good in terms of blood pressure reduction and just as good in terms of proteinuria. And there's some evidence it might be beneficial in helping fibrotic conditions as well. A question about supplementing with keto analogs, not mainstream, and low protein. I'm going to look at low protein GFR. Honestly, evidence is weak. I'm cautious about low protein diets. If you've got an overweight diabetic patient, they can't have, what can't they have? They can't have salt, they can't have sugar, they can't have protein, they can't have probably phosphate as well. It doesn't mean there's a lot left, is there really? And I think low protein diet in clinical practice is awfully hard to do. Supplementing with keto analogs to try and reduce the risk of malnutrition and stuff. Honestly, I don't think there's enough evidence to really support that, except perhaps in exceptional cases. Do you advise your patients to get the magnesium test reported too? No, I don't on a regular basis. Of course, you know what? If they're on drugs like antacids, obviously the PPIs, very, very well that PPIs are associated with chronic kidney disease. And I think I haven't mentioned, but it's true of every chronic kidney disease lecture. You have to look at all the other drugs they're on, every drug they're on, and ask why. Why are you on this drug? Because you had some indigestion 11 years ago. Nobody's taken you off your regular PPI, but they're associated with hypomagnesemia and with chronic progressive interstitial nephritis and kidney disease. I think you should stop them or reduce them or talk to the patient about why you're continuing with them. It's responsible medicine. And patients shouldn't simply accumulate a new drug every single year, because by the time these drug patients reach dialysis, they're on 20 or 30 different drugs, and it's complete implausibility that we'll be taking them all properly. That's my view anyway. Um, any other questions? Because I've answered about 15 so far. I don't see any further typed questions, but I'm very happy to stay on for another few moments if you want me to. If not, we can close. I'm very happy. Oh, no, here we are. We've got one. A 47-year-old newly diagnosed hypertensive female patient is obese, non-diabetic. So she's obese, she's non-diabetic, first choice antihypertensive. Well, I'm assuming she hasn't got kidney disease or proteinuria. I think there you can be you've got a lot of options. You see, what you've got to remember about antihypertensives, and I don't know why people don't remember this, is that not every drug works in every patient. This is a patient who might be suitable for amlodipine, but you know what? Overweight, middle-aged to old, middle, let's call her middle-aged. Let's not be rude. 47. These sorts of patients are very prone to ankle swelling. So my prediction is that while amlodipine would be very reasonable to start for her on, you might well find this is a patient who comes back very quickly with ankle swelling. So maybe we actually just go to an ARB here. There's no direct indication for an ARB. There's no albuminuria or reduction in GFR. But don't forget, ARBs are very good antihypertensives. They've got an excellent effect on blood pressure reduction, and they're good at reversing their ventricular hypertrophy. So maybe that would be your answer. Would I give an overweight patient who's obese a thiazide? Yeah, no, not really. Very old-fashioned medicine, liable to cause a number of electrolyte disturbances, make her sugar worse, maybe give her gout. No, don't like that actually. Don't think that's very sensible. That's just my personal view. How often do we monitor serum creatinine and electrolytes in patients with CKD and ARBs? Depends on the stage, doesn't it? If they've got no evidence of kidney failure whatsoever, then of course, when you start an ARB in any patient, and I'll repeat that, any patient, you should recheck their electrolytes. That's potassium and creatinine. But obviously, you're going to do the others, aren't you? You can hardly be selective with the modern multi-channel analyzers. You're going to do them both, and you're going to do them about 2 weeks after you start, just in case you're going to pick up renal artery stenosis, desperately rare but possible, hyperkalemia, or some other untoward complication. Once you've got that done, you really will only need to measure them again if they're at risk of developing kidney disease or problems or progressing. So, or if you change the dose. If you change the dose, you should really, as a counsel of perfection, remeasure the creatinine and electrolytes all over again. Now, of course, if they're CKD stage 3 or 4 in particular, you're going to have to see and measure these people 4 times a year. You are, or the GP is, for sure. So, diuretics, except for calcium channel blockers, diuretics, centrally acting agents. Well, I'm not sure I understand, but what are the classes of antihypertensives prescribed in end-stage renal disease? Oh, you mean in patients on dialysis? Well, the evidence that anything works well on dialysis is very modest, actually. And in terms of drug trials that have looked at the efficacy of antihypertensives and looked at the different classes, there's almost nothing out there. Now, there's not a lot of use in using a diuretic. I think you'd agree with me. But almost everything else can be used in patients on dialysis. My view is that the antihypertensives don't work very well in patients on dialysis. And what you should be focusing on is getting proper volume control by stripping out excess fluid. Proper duration of dialysis sessions, proper salt restriction is vastly more effective than throwing drugs at people almost certainly that they don't take. That's how I would approach it, actually. I do accept that patients who don't turn up for the dialysis, don't have enough dialysis when they are there, don't respond to diet, and don't take advice from doctors. I don't think there's very much that you and I can do in that setting to improve the situation. I'm sorry about that. Any others in our last 5 minutes? Because we've had about 20 now, I think, which is good. You've been a very interactive audience, and I hope that's been a helpful talk. So I'm very happy to answer 1 or 2 more. If not, you can go and enjoy the rest of your evening. I'll leave it with you. I shall count down in a moment. No, I think that's fine. I think we probably can wrap it up and say thank you very much for listening. I hope you found that valuable. I hope you'll listen to it again. and you're welcome to contact anybody in the webinar team, of course, if you want more information, but don't contact me directly, I'm afraid. That will be difficult. Thank you very much. We're going to stop now, and I'll see you again another time. Bye-bye.